This conference will now be recorded.
So today we are going to discuss about this April 2020 TOG article, that is perioperative management of women on anticoagulants and antiplatelet agents who are undergoing gynec surgeries. Okay, so this talk basically covers the different anticoagulants used for the VT or who are at the risk of thromboembolism, like warfarin, newer anticoagulants, and antiplatelet agents like aspirin and clopidogrel, and how they should be managed during the gynecological surgeries, like for elective and emergencies where the bridging is required, which are the high risk procedure and what should be done. So this is the basic overview of this talk. So we'll discuss this now. So in the introduction, what they have stated is in the past few years, because of there is increased survival rate with all this cerebral vascular accidents, cardiovascular accidents, and all the thromboembolic disorders, there is significant increase in the number of patients who are currently on anticoagulants. Also, there is change in the type of anticoagulants which was used. So previously, warfarin was the main anticoagulant which was used, but now there are direct acting anticoagulant agents are there. So direct oral anticoagulants, these are becoming increasingly popular and they are as effective as warfarin. They do not require this INR monitoring, and the agents which are used as direct oral anticoagulants are apixaban, rivaroxaban, dabigatran, and edoxaban. So now, whenever the patient is undergoing elective gynecological surgery and who are on anticoagulants, how they should be stopped or how they should be monitored. So first, in preoperatively, careful assessment of the patient and the procedure-related risk of thrombosis and bleeding is essential. So there are two things: whether the patient is high risk for thromboembolism or whether the patient is high risk for bleeding. This is the one thing, and another is what is the procedure. So whether this procedure is at high risk of bleeding. So procedure involves whether it is a major procedure, minor procedure, where there are chances of hemorrhage are less or more. So these two are the things they should be taken into consideration, and careful balance should be achieved between the thromboembolism and hemorrhage risk. So it can be either discontinuation of oral anticoagulants and antiplatelet agents or the need of the bridging therapy with low molecular weight heparin, and when to stop this anticoagulant and when to restart this anticoagulant. So all this should be carefully monitored and all this should be carefully taken into account. So whether to stop it, whether to bridge with another anticoagulant short acting, that is low molecular weight heparin, when to stop it and when to restart it. These are the major considerations while the patient is undergoing elective gynecological surgery. So this preoperative assessment, it should be done at least 7 days before the surgery to allow effective perioperative anticoagulation planning, especially before any major surgery. So now they have divided this into women taking warfarin, women taking direct oral anticoagulants, and women taking antiplatelet agents. So how these should be managed? So for first is what the group they have taken is women taking warfarin. So all the patients who are taking warfarin, they should stop the treatments 5 days before the surgery, irrespective of their risk of intraoperative bleeding. So warfarin should be stopped 5 days before the surgery, whatever is the risk of the bleeding. Now, depending upon the patient's risk, whether she is at high risk of thromboembolism or she is at low risk of thromboembolism, it will depend whether the bridging is required or not. Bridging means substituting the warfarin with low molecular weight heparin, which is a short acting. So the patients who are at high risk of thromboembolism require bridging with treatment dose low molecular weight heparin. Now remember, it is a treatment dose, it is not prophylactic, but this warfarin should be replaced with therapeutic low molecular weight heparin doses, and the last dose should be given 24 hours preoperatively. Post-operative bridging, it should not be started until at least 48 hours after the procedure where there is a high bleeding risk. But thromboprophylactic dose, so prophylactic low molecular weight heparin dose can be considered before 48 hours also if she is at high risk of thrombosis. So if the procedure is at high risk of bleeding, or if the patient is at high risk of bleeding, then bridging again restarted at 48 hours after the procedure. If the patient is, or the if the bleeding is not at the procedure is not having high bleeding risk, warfarin can be resumed with a normal maintenance dose on the evening of the surgery or next day if the hemostasis is adequate, because the onset of action is warfarin is low, and to achieve the desired INR it would take more than 24 hours. So if the patient is not at a very high risk of bleeding, then the warfarin can be started on the day of the surgery at the evening dose or in the next day. Okay. And the bridging of low molecular weight heparin, it can be started at 24 or 48 hours. And this bridging, so this low molecular weight heparin plus warfarin, it should be continued for 48 hours at least to achieve the desired INR, because because the warfarin is long acting, this INR therapeutic INR, it takes almost 24 hours. And so, as I told you, this bridging therapy should be continued until the INR is in therapeutic range. The women with low thromboembolic risk, they do not require bridging therapy. So now, who are at the risk of bridging? So who requires this bridging therapy, or who are at the high risk of thromboembolism? So the patient who is having the history of VT. Okay, so if the VT is in the previous 3 months, then these people will require bridging with the low molecular weight heparin. Also, very high risk patients for VT, where their target INR is in the range of 3.5. So the warfarin dose is maintained to maintain the target INR of 3.5. So that should be the patient who requires bridging. Also, the patients who are at risk of atrial fibrillation or history of atrial fibrillation, like patients who had a stroke or transient ischemic attack in the last 3 months, and patient who had a previous stroke or TIA in 3 or more months with following risk factors. Okay, 3 or more following risk factors, that is congestive cardiac failure, hypertension more than 140/90 on treatment, age more than 75 years, and diabetes mellitus. So if any 3 of this is positive with previous history of stroke or TIA, they should require this bridging. Also, the patients with mechanical heart valve other than those with bileaflet aortic valve. So mechanical heart valve patients, they require bridging. Previous VT, they require bridging. And the patient who are at risk of atrial fibrillation or with history of atrial fibrillation, they require bridging. Well, other patients who are at low risk of thromboembolism, they don't require bridging. Only thing is warfarin should be stopped 5 days before the surgery, and it should be started 24 to 48 hours after, depending upon the risk of the bleeding during the surgery. Now, women who are taking direct oral anticoagulants. Now, there is not much study regarding this, but what is the current guidelines which are published by British Society of Hematology? It suggests that it is the responsibility of the operating surgeon, and this stoppage and recommencing should be taken on the case by case basis, and it depends upon the bleeding risk and woman's renal function. So at the end of the talk, they have given one table where they have written for individual this direct anticoagulant agents, when it should be stopped and when it should be recommenced. So we will look at the table at the end. Now, women who are taking antiplatelet agents. So antiplatelet agents means aspirin and clopidogrel. So clopidogrel, it is a ADP receptor antagonist. These are the commonly used antiplatelet agents, and they are used for the secondary prevention of cardiovascular disease. So it can be a single agent, or dual antiplatelet agents is also used for the ischemic cerebrovascular disease. So for aspirin monotherapy, aspirin can be continued safely for gynecological procedures. Remember well, aspirin can be continued. There is no need to stop aspirin if she is on aspirin monotherapy. Now, if the patient is taking dual therapy, that is aspirin plus clopidogrel, then, and this aspirin and clopidogrel, if it has been started because of acute coronary event, then the surgery should be postponed at least for 6 months. If it is elective surgery, it should be postponed for at least 6 months. If the patient is taking aspirin plus clopidogrel for any acute coronary event or coronary artery stenting. If the delay is not possible, then liaison with hematologist is maintained. Clopidogrel and aspirin can be continued for procedures with low bleeding risk. And for high bleeding risk, aspirin should be continued with temporary discontinuation of this clopidogrel. Ideally, this elective surgery who are at high risk of thrombotic, it should be deferred until they become the low risk. Okay. So unless this risk stratification, it comes to the low risk. If the patient is taking dual this agents, it should be postponed till they become lower risk patient. Now, as I told you, these surgeries again they are classified into depending upon their bleeding risk. So for gynecological surgeries, they have classified into no bleeding risk, minor bleeding risk, and major bleeding risk. So no bleeding risk surgeries are pelvic examination, smear, and genital swabs. So see, there is no bleeding risk. You can anticipate that. Now, minor bleeding risk, all small procedures which are involving the hysteroscopy and any cervical colposcopic procedures. Okay. So cervical biopsy, diagnostic hysteroscopy and resection of polyp, Bartholin's abscess, large lobe excision of transformation zone or leads, polypectomy, Neuraxial ablation, pupil biopsy, TCRE and vulval biopsy. So all these small procedure, hysteroscopic and colposcopic and small biopsies, these are minor bleeding risk. While any daycare cases and inpatient surgeries, they are considered to be at a major bleeding risk. Okay. So I think there was previously one question whether this tubectomy. So any lap tubal ligation comes under a major bleeding risk, remember well. Now for this procedures where there is a low bleeding risk and if you are doing with this antiplatelet agents, then for minor procedure like leads, if there is unexpected bleeding occurs, Monsell solution, that is ferric subsulfate or cauterization with silver nitrate can be used to stop the bleeding. If the bleeding ensues, then one should consider vaginal packing. Okay. So first treatment is Monsell solution or cauterization. It can come as an EMQ, remember well. So patient is on antiplatelet therapy or on warfarin and she has been posted for leads and she starts bleeding. So first option will be Monsell solution or cautery with silver nitrate. Then next option will be vaginal packing. Like small procedures like Bartholin's abscess or excision. Then if the hemostasis is not ensured or achieved, it is a electrocautery or oxidized cellulose can be also used. Now for emergency. So this we are talking about the elective gynec surgeries. Now coming to the emergency gynecological surgeries. If the woman is taking warfarin. So what this British Society of Hematology guideline says that if the surgery can wait for 6 to 8 hours. So if the patient is taking warfarin and surgery can be postponed for 6 to 8 hours, then give 5 milligram of intravenous phytomenadione, that is vitamin K, is given to achieve desired INR and restore coagulation factors. So for warfarin, vitamin K can be given if the surgery can be postponed for 6 to 8 hours. Now, if the surgery cannot be postponed, then 25 to 50 unit per kg 4-factor prothrombin complex concentrate. So, this is the thing which should be given if the patient has to undergo emergency surgery and if she is on warfarin. Okay, so the dose is 25 to 50 microgram per kg 4-factor prothrombin complex concentrate. It is the antidote for this warfarin if the patient cannot be delayed for surgery. Post-operative management, it remains same as that of a elective surgery. Now, the emergency management if the patient is taking direct oral anticoagulants. Vitamin K will not help. Now, this is the talk which is saying that you can give vitamin K for if you can prolong for 6 to 8 hours, you can give vitamin K. If you want to do the immediate surgery, you have to use this prothrombin complex concentrate. Okay. Now, if on direct anticoagulants, then if it is possible, surgery should be delayed to allow the plasma level of drug to fall. Now, how you are going to see this plasma level? So it depends upon the dose of the drug, half-life of the drug, and renal clearance, woman's renal function, and time of the last dose. If it is not possible to delay the surgery, tranexamic acid can be used to reduce bleeding. and drugs that impair hemostasis like NSAIDs, it should be avoided. So give tranexamic acid, avoid NSAIDs, decide the drug concentration, and depending upon that you can either see if surgery can be postponed, and if the emergency surgery is required, then take her for the surgery, but be ready with tranexamic acid. Then idarosizumab. So idarosizumab, it is a drug which can use to reverse the effects of dabigatran before emergency procedures with high bleeding risk. So this is a drug that is used as an antidote of dabigatran, that is idarosizumab. Okay. A normal thrombin time can indicate minimum circulating levels of dabigatran. Now, emergency gynecological surgeries if the patient is taking antiplatelets like aspirin and clopidogrel. So aspirin, as you know, it can be continued. So there is no contraindications for this aspirin. But yes, there is no reversal agents for clopidogrel. And its effects are irreversible. And this platelet inhibition lasts for at least 7 to 9 days. Okay. So this drug effect lasts for at least 7 to 9 days as far as the lifespan of platelet is concerned. So the patient who are on clopidogrel who requires emergency procedure with high bleeding risk, this British Society of Hematology, it recommends that use of tranexamic acid can be considered. If there is still excessive bleeding, 2 pools of donor platelet infusion can be given. Okay. So first, give tranexamic acid. If the patient is still bleeding, give 2 pools of donor platelets for this clopidogrel. Now coming to the neuraxial anesthesia. So neuraxial anesthesia is considered as high risk, very high risk intervention, like spinal or epidural analgesia is considered as very high risk intervention because it can be associated with neuraxial hematoma, and then it will be can be life threatening also. So spinal and epidural anesthesia can be undertaken without sedation of NSAIDs or aspirin, but patients on ADP receptor antagonists like clopidogrel, it should have been discontinued the medication at least 7 days before the procedure. So clopidogrel should be stopped at least 7 days before the procedure. Aspirin can be used. Aspirin can be spinal and epidural can be given with the continued use of aspirin. And the timing of neuraxial anesthesia are similar to those when planning for high bleeding risk. So this is the table which is given in this talk, and this is the basic important, all the things are included in this table. So warfarin, it inhibits vitamin K epoxide reductase. So it prevents vitamin K dependent factors like 2, 7, 9 and 10. 2, 7, 9, 10. Warfarin. Okay. Half-life is 36 hours. Elimination occurs 92%. When the patient is at low bleeding risk, as I told you, warfarin in both low bleeding risk and high bleeding risk, it should be stopped 5 days prior to the elective surgeries. Check INR, ideally the day before the surgery. If the INR is more than 1.5, give vitamin K, phytominidone, okay, on the day of surgery. Same with high bleeding risk. Also, the bridging can be considered when the patient is at high risk of thromboembolism. When it should be restarted, the patients with low bleeding risk, warfarin can be started if the adequate hemostasis is achieved within 12 to 24 hours. And low molecular weight heparin should be started 24 hours after the surgery. For high bleeding risk, as I told you, LMWA should not be started until 48 hours after the surgery. Warfarin can be started when the bleeding risk is minimized. LMWA should be continued in both low molecular and low and high bleeding risk. It should be continued until this INR comes in the therapeutic range. Mechanical thromboprophylaxis should be considered in all cases until INR comes to the therapeutic range. So this is regarding warfarin. Now coming to this apixaban, rivaroxaban and edoxaban. So these three are different and dabigatran is different. So these three are factor 10A inhibitor. Apixaban, see, all this in these all three contain X in it. Okay, so it is factor 10 inhibitor. Factor 10 inhibitor, all three contains X in their names. So half-life is almost, it is between 8 to 10 hours. Elimination is mainly by renal excretion and liver excretion also. So it should be stopped If the creatinine clearance is normal, it should be stopped 24 hours prior. If the creatinine clearance is less, it should be stopped 48 hours prior for low bleeding risk. For high bleeding risk, if the creatinine clearance is normal, it should be stopped 48 hours before. If the creatinine clearance is less, it should be stopped 72 hours prior. It should be restarted within 6 to 12 hours within the procedure, after the procedure, if the patient is at low bleeding risk. If the procedure is of high bleeding risk, wait for 48 hours before starting it. If the VT risk is high, you can consider prophylactic anticoagulation, prophylactic dose of anticoagulation. Now, dabigatran, see, there is no X in this and it is a 11A inhibitor, factor 11A inhibitor. Half-life is somewhat more, 13 to 18 hours. Elimination is mainly renal. So here, remember, creatinine clearance, there it was 30 creatinine clearance, 30 was considered as normal. Here they have divided into 3, 80, 50 and 30. So if the creatinine clearance is more than 80, stop 24 hours prior. Creatinine clearance between 50 to 80, stop 48 hours prior. Creatinine clearance is more than 30 but less than 50, stop 72 hours prior. And for high bleeding risk, again, just it has increased by 24 hours. So 48, 72, 96. And restarting similar to that of that is apixaban and all these things, start 6 to 12 hours after the procedure, and for high bleeding risk, wait for 48 hours. Now coming to these antiplatelet agents. So aspirin can be continued before the procedure and post procedure also. There is no contraindications for aspirin. Clopidogrel, usually it should be stopped at least 7 days prior to the surgery. So if the patient with a recent coronary syndrome or coronary artery stent on dual antiplatelet therapy, it is important to assess the need of surgery. Okay, so it can be postponed for at least 6 to 8 months. If the patient is at high bleeding risk, basically, if possible, postpone the surgery. If not possible, stop the medication 7 days. So for clopidogrel, what you have to remember is stop the medication 7 days before. Restart, it can be restarted after 12 to 24 hours after the procedures. So all this is clopidogrel, asugrel and ticagrelor. So all these are this newer antiplatelet agents, or it is P2Y12 inhibitors. So this is regarding this talk. This is actually a short talk, but the important thing that you should remember is when it should be started, when the bridging is required, and what are the procedure for different anticoagulants. So coming to the question, you can type the answer in your chat box. A 65-year-old woman who has an episode of postmenopausal bleeding, she is on warfarin for atrial fibrillation. She is scheduled for outpatient hysteroscopy and biopsy. What post-operative anticoagulation will you advise? Yes, answers please. Yes, correct. So it is, you should start warfarin within 12 hours and low molecular weight after 24 hours. Okay. Next one, 50-year-old woman who is on dabigatran for embolic stroke. She requires emergency surgery for ovarian cyst. How can the effects of her anticoagulant can be reversed? Yes, it is idarucizumab. Answer is B. So this is regarding this perioperative anticoagulant requirement for gynecological surgery. So tomorrow we will meet with another talk. Bye till now. Thank you for attending it.
Thank you, ma'am.
Thank you.
Thank you.